Good morning, everybody. Good morning for me. It could be good evening for you, depending on what time, what place, what part of the world you are from. My name is Igor Kutsenok, and I am directing the International Technology Transfer Center, Ukraine, and I'm a professor of psychiatry at the University of California, San Diego. We continue our series of webinars that will be followed by consultations and case reviews on the various issues of trauma, war-related trauma, which is extremely important in Ukraine, considering everything that Ukraine is going through. And today, the focus of the conversation today will be on the specifics of trauma work with combat military, people who are actually fighting. This is a very specific culture. The expression of trauma is different, and many things are different. So with the best, even if you have the best intentions to help, and all of you do, without skills, knowledge, and understanding, it would be difficult for you to do it. And it's conceivable that by not gaining skills, you may get things worse. So today we are really lucky because the leader, the presenter for the workshop today is Dr. Darlene Baker. She's a professor of psychiatry at our university, University of California, San Diego Department of Psychiatry. And she's a world-class expert in exactly addressing the issues of trauma, psychological trauma, in combination with brain injury or without combination with brain injury, specifically in combat military personnel. So I will give the floor to Dr. Baker. And again, I want to thank you, Dr. Baker, for your time, for preparation, for attendance, and for sharing your knowledge. There is no doubt in our mind that Ukraine will win, but the long-term consequences of the conflict will be a big part of it, not just economic, but psychological, including psychological problems in combat veterans. So it's better to start preventing it now as much as we can and doing something about it now. So Dr. Baker, the floor is yours. Thank you again. And I wish you a wonderful workshop.
Well, thank you for the opportunity to talk with you. The content of this talk may be relevant if there happen to be any line military members in the audience, but also might be relevant to firefighters or rescue workers, as well as definitely military medical support personnel. The first half of the talk will be directed a little more toward some of the preventive measures and toward line military, with the second half toward more diagnostics and some of the duties of the medical support personnel. And I go over generally the framework for management of operational stress. I'll talk about acute stress reactions. I'll then talk about the identification, triage, and diagnosis of stress injuries, and particularly with a focus on early identification and awareness of identifiable risk factors. And lastly, combat-related PTSD and what we're now kind of understand about long-term trajectories and their public health considerations. The risks for adverse health consequences in the military extends through enlistment and, of course, the combat deployment and actually into post-military life. Combat operations involve exposures to potentially psychologically traumatic events, and they can have severe impact on physical, mental, and social health. Current approaches to interventions for adverse psychological consequences of combat rest upon concepts that really began as frontline psychiatry, first developed around World War I. The references at the bottom of this slide address some of the history, as well as a couple manuals related to current practice. And these manuals are put out by our NATO manuals that are accessible, openly accessible on the internet. A Leader's Guide to Psychological Support Across the Deployment Cycle, and Forward Mental Health Care. Oops. And the militaries, including those of NATO, use a conceptual model called the stress continuum model, and this has been around for a while. And the model ranks stress levels and common behaviors at those levels across a continuum from healthy, which is under the green, to reacting, which involves reacting to everyday stressors, to injured and ill. And I'm not going to go through this particular slide in detail, but you can find this same continuum model in the documents I just referenced, as well as in the slides that are put up once this talk is over. The healthy levels, of course, designate behaviors associated with most emotional regulation and adaptability. And over the next few slides, I'll be talking about some resilience building or possible preventive strategies to help troops maintain stress within the green and yellow zones. Behaviors observed under the orange or red zones can signal extreme stress within which stress injury is a possibility, and observed behaviors may be associated with stress injuries, such as acute stress disorder, or post-traumatic stress disorder, or other associated mental health problems. The framework followed by the NATO countries is that the chain of command has the overall responsibility for the psychological welfare of the service members under their command. And they do this with the help and support of mental health staff. The mental health staff support role is to be present or nearby at training and or during combat operations for clinical assessment, and if necessary, for triage away from the front line, engagement and treatment and rehabilitation as they're needed. Also, they're should be available for education or mental health promotion to groups considered to be at high risk, such as, for example, body handlers. Otherwise, they also may be needed for various advisory support for specific instances. And as you can see from the graphic below, the role of the mental health personnel increases as you move toward the injured and ill. So I'm going to spend quite a bit of time on this slide because it really underpins the rest of the talk. The brain and the response to stress, which is initiated by the brain and involves the entire body response stress system, really underpins the development of stress injuries. In short, the brain's job is to ensure survival. A simple way to think about the brain is to think about it as somewhat of a hierarchy, with the most primitive part of the brain in the bottom or brain stem area of the brain. You can't see that well in this picture. It's down toward the back of the brain and the neck area. This part manages basic body functions. It's what sometimes is called the reptilian brain. The middle part of the brain, the limbic system, which is represented in this picture by the amygdala, is the emotional center of the brain and the outer part of the brain. Of course, the cortex is the most highly developed in humans and is the thinking part of the brain. And this you see on the outer edge, of course. Under calm and normal stress circumstances, these parts of the brain, as well as the body, communicate with each other in a very responsive and flexible way as stresses arise. And they keep the body, they keep individuals calm and in homeostasis. Each general component of the brain does its part in management of survival and stress. In close communication with the body, the deeper reptilian brain manages all the major functions of life. And it's some of the things that you'll see in relation to behavior. For example, sleep, eating, pain, circulation, and breathing. The middle part of the brain, the limbic brain, that includes the amygdala, makes emotional judgments about things. When it senses danger, it can initiate pre-programmed escape plans like fight or flight responses. And these muscular and physical reactions are automatic, are set in motion without any conscious or awareness thought or planning. They sometimes, of course, leave then our conscious rational capabilities to catch up with what happened later. The cortex, or the thinking brain, the most recent to develop on an evolutionary scale, and the last to fully mature in humans. In fact, the cortex doesn't fully mature until the mid-20s, is the executive center of the brain, the part of the brain that's essential for careful planning and anticipation, for inhibition of appropriate actions, and for the ability for empathic understanding of others, for emotional intelligence. The flexible neural communication between the amygdala and the frontal cortex are crucial for accurate reading and response to the environment. And additionally, the flexible neural communication between the amygdala and frontal cortex in our fellow humans permits empathic, harmonious, and coordinated interactions, the kind of interactions that can permit a close-knit military unit to function successfully. The body response to emotional capture of the brain by the amygdala is a change in the body systems, and that includes an outpouring of stress hormones such as cortisol and norepinephrine or adrenaline, a shift in the autonomic nervous system, and that's controlled by the vagus nerve, the large neural highway between our body and our brain. And that shift is from predominance of a parasympathetic to a sympathetic tone. And essentially that prepares the body to either fight or flee. And it essentially kind of shuts down growth and digestion. It increases heart rate, it increases blood pressure, it pours out glucose for energy, and it gets us ready for potential injury by increasing inflammation. As stress increases, the neural communication between the thinking and the emotional brain can actually be disrupted. Essentially, the amygdala can begin to take over. If the disruption is flight and the recovery time is sufficient, the brain and the body can often recover and adapt, such as in acute stress reaction, which I'll talk about later. If the stress is sufficient, the brain systems can begin to lose plasticity, and the body functions can be unhealthy and lose their adaptability. And the person can move into a chronic stress situation, such as moving from an acute stress disorder to chronic post-traumatic stress disorder. And poor health. So knowing the physiology, one can begin to approach general prevention of stress-related health disorders by trying to build in resilience training into the regular training schedule that is standardly done in the military. And the hope would be to, at least as the skills training is occurring, to build in some resilience training mechanisms and time. And I'm just going to go over a few things that could be begin to be built in. First of all, the one approach would be to make attempts to enhance the parasympathetic tone. In some ways, that is done automatically with some of the training as the physical fitness increases. And so let me talk about how we can potentially measure that. The heart rate, of course, tends to be lower as the parasympathetic tone is higher. And there's something called heart rate variability, which is the heart rate beat to beat variability, which, if more variable, signals a higher sympathetic tone, and if more very persistent or consistent, begins to signal more of a stress or sympathetic tone. And so if one has, one always, of course, has the pulse to use to measure, to try to bring the pulse rate down through additional fitness training. But if by chance the sort of wristwatches or other measures of heart rate variability are available, the heart rate variability can be used as a measure of a sympathetic tone, and one can then train to a window of tolerance. I should note here that parasympathetic tone is relevant to both the physical fitness and to anxiety. Parasympathetic tone is decreased under higher mental anxiety. Of course, it's increased with greater physical fitness. Another way to potentially increase resilience is through training of various mental skills, again, that are accessible through body signals. And one would be calming breath techniques. There are numbers of these techniques. If you look on the web, the one that I suggest here is a breathe in 4, hold, breathe out 5, but there are many others that could be used. This is helpful mechanism when the amygdala is beginning to discharge and essentially beginning to capture the activity of the brain and body. Yoga techniques and mindfulness meditation are helpful. And one of my colleagues that I work with here in San Diego, if there's an interest in learning more about those, could give a talk later in this series. Healthy behaviors are extremely important because unhealthy behaviors such as poor sleep, heavy use of alcohol, or unhealthy diet both increase stress hormones and increase inflammation. And both of those are important to reduce reduce vulnerability to post traumatic stress or moving toward a stress disorder or moving toward a chronic stress state. The other really useful or important thing that to be considered in the line military is strong development and maintenance of strong unit cohesion. And I think of this again through the amygdala. I'm trained as a child psychiatrist, and Winnicott in child psychiatry talks about the holding environment. When the amygdala is developing, if the environment is such that allows exploration and growth in a feeling of safety, this is embedded within the amygdala, and there's a general lowering of stress levels. A healthy unit can provide that kind of support through co-regulation, through basically defined as a warm and responsive interactions that provide support, coaching, and modeling among all of the peers in the unit. This environment decreases negative amygdalar discharge, reduces stress, allows for more thinking. That would be unit coordination and planning. And particularly important to watch out for as disruptive to this kind of cohesion would be loss of or turnover of unit members or leadership, especially right before a deployment, or any kind of hazing within the unit, as well as prolonged or repeated deployments. There are a number of stresses in combat operations, not just life threat. Of course, life threat is there, and that would be exposure to lethal force or its aftermath in ways that exceed the individual's capacity to cope normally with the moment. And that might provoke feelings of terror, horror, or helplessness. And it's that life threat that will often be cited as the initiator of the event that set off a chronic PTSD episode. However, other kinds of wear and tear and loss occur that are extremely important for development of chronic illness. A second one is the loss, death of close comrades, leaders, or other cared for individuals, perhaps family members, or loss of relationships, or even aspects of oneself or one's possessions. Additionally, inner conflict, or some of my colleagues like to call it moral injury, is moral damage that can can be felt from carrying out or bearing witness to acts or failures to act that violate really deeply held belief systems. And lastly, for redeployments or for long deployments is just accumulated wear and tear, accumulated effects of smaller stressors over time from sources such as lack of sleep and lack of rest and restoration due to operational tempo. So what I'm going to begin to address here is some of the potential dangers of these kinds of stresses and how they may begin to impact mental health. And the most immediate way on or near the battlefield is acute stress reactions. Now, these, as defined by the ICD, are not considered a mental health disorder. They're still considered within the normal range of of reaction. Synonyms for this are combat stress, battle fatigue, battle shock reaction, combat stress reaction, or battle stress reaction. And it's basically the development of a transient emotional anxiety or cognitive or somatic symptoms as a result of exposure to some kind of extreme event on the battlefield. These are usually expected to subside within a few minutes to a few days. And I'll talk about some research that is currently being done on acute stress reactions. With these, acute impairment usually doesn't occur, but it can persist. Essentially, acute stress reaction is a sign of excess amygdalar discharge. The amygdala more or less takes over the system, and the thinking brain goes offline, and there's a dissociation. The number of likely acute stress reactions is more or less unique to any specific combat operation and can be linked to the operational tempo, the nature and duration of the deployment, other factors such as physical health, home factors, occupational stressors. So these are currently being studied, particularly in the US and in Israel. The statistics I'm going to be citing here are largely from Adler and Gutierrez, although they also include some from papers by the Israeli group. So the acute stress reaction during combat operations aren't uncommon, is what they're saying clearly. And this is based on data from these studies that show that they occur somewhere between 17 to 29% of the time, according to combatants who had endorsed experiencing themselves these acute stress reactions. This research indicates that the percent experiencing an acute stress reaction is broad. It doesn't differ by gender, but it's reported by every rank in the military, the junior enlisted, the non-commissioned officers, as well as officer ranks. And the acute stress reaction can impact perception, auditory distortion, there can be tunnel vision, often there's temporal slowing, and a change in decision making. And of course, this can endanger the unit as a whole, potentially. The acute stress reaction is observable by other unit or team members. Around 40 to 50% of the individuals queried endorse observing acute stress reaction. The most common description from them being that the person didn't seem to be able or was unable to function, and they were increasing risk to the unit. So what they did was to look at what might be the duration of these acute stress reactions. And overall, less than around 48% were quite short and lasted less than 5 minutes. However, slightly greater than 50%, 52% lasted more than 5 minutes, with 19% lasting a day or more, and around 12% lasting really fairly long time, around 3 days or more, bleeding into the time when you need to seriously consider whether this is has become or is an acute stress disorder, and where referral for diagnosis would seem indicated. There's some evidence that unit members who observe acute stress behaviors in a peer might be themselves negatively affected, that they might actually later themselves have higher rates of PTSD. And so the hope is that training, pre-training before going into the combat regarding peer support may help the unit manage acute stress experience and exposures better, and that training may help reduce acute stress reaction stigma, both feelings of self-stigma. If somebody has a reaction, often there's a feeling of chagrin or shame, or for the other unit members to stigmatize the person for whom that occurred. The peer support training's in development now in the US. It's under a name of iCover, and Israel under the name of Yahalom, and other NATO militaries also are developing this training to optimize the peer detection and response to acute stress reaction. These training programs are currently being assessed for acceptability and effectiveness. However, the long-term benefits are suggestive but are not yet proven. So the guiding principle for these interventions are that they be consistent with research evidence of the known physiology of acute stress, and that would be, again, this amygdalar discharge and essentially beginning to be disconnect between the frontal lobes, the thinking brain, and the emotional brain. That they integrate forward psychiatry concepts that have inherent military culture meaning, such as immediate return to functioning, commitment to mission, and social support, that they're simple enough to be delivered by non-professionals, and that they're practical for rapid delivery in a high-stress context. Relying on team members to address acute stress reaction is a practical solution, and it's consistent with military culture. Additionally, the resilience techniques that I talked about earlier in this talk, if taught during training, could be applied here as additional help to bring the person back who is having an acute stress reaction. So I'm going to go fairly quickly through this slide to talk about what they're suggesting for the training. But again, if there's an interest in this, it should be folded into any training program and would take much longer than my simple description. So again, the bottom line is behind this is to bring the thinking brain back online. And so the first step is usually to somehow the person feels disconnected, is staring, might be shaking, clearly off in their own world. The first step is to connect with that person any way possible, make eye contact if that works, call the person's name, squeeze the person's arm, basically ensure that the person pays attention using some different sensory channels than whatever you need to connect with that person. Emphasize then, once you've connected with that person, emphasize commitment, assure the person that he or she isn't alone, that you're present, and break through the sense of isolation. Next is slowly begin to really bring the thinking brain back into functioning. Ask simple, as the individual, simple fact-based questions relevant to the present moment. Do you know how we got here? What time is it? Engage the frontal cortex, engage the thinking brain in a very simple way. The next step would be to confirm the sequence of events of what led up to the present moment. Describe in simple language what has happened, what is happening, and what is being planned next. That is, basically orient the person using a variety of grounding statements. And lastly, give a simple order to direct the person to carry out a specific action, and basically begin to prompt the person to begin functioning, and thereby reduce the sense of helplessness that the person is experiencing. It's at this stage that it's important to begin to make a decision about a further assessment of the combatant. Effective management of the mental health problems is basically a force multiplier. The specialist mental health capability is part of the overall operational medical support. And so while many combatants with acute stress reaction will recover quickly, close to the event, with the expectation that they return to full function in line with the principles of frontline psychiatry, basically in the proximity of the fighting, and to re-engage quickly with the unit. Others may need mental health diagnostic evaluation and actually may need to be triaged and treated. And I'm gonna go from acute stress reaction here then to start talking about acute stress disorder. As we noticed in the earlier slide, a significant percent of individuals with acute stress reaction had the reaction last 3 days or more. And the acute stress disorder, one of the diagnostic criteria, of course, for acute stress disorder is lasting 3 days or up to a month. And so you may, if you're an allied military mental health person, want to go over the diagnostic criteria for acute stress disorder to determine if this person is experiencing this problem. The most salient diagnostic criteria for PTSD is the re-experiencing component. It really doesn't exist anywhere else in any other psychiatric diagnosis. And it's also one of the most distressing symptoms of the disorder, and basically is a replay of the traumatic event with all of the emotions that occurred at the time of the event. And it can be reoccurrent images, and it usually comes in some kind of perceptual modality, either a visual image, or it can be an auditory replay of something that was heard. It can be a smell. It can be touch. And these replay as if on a loop that just plays again and again. And it tends to occur when the person relaxes or tries to go to sleep, and it recurs at nightmares during the night. And so one of the first things that tends to happen is that it automatically disrupts relaxation and sleep. And for some people, there's a very strong over time effort and tendency to avoid any stimuli that call up this reminder. So there may be a tendency to avoid places, people, feelings, objects, conversations, anything that might remind the person of this event. And this avoidance category of symptoms is one that is important because it prevents safety learning, or it prevents new learning, and it begins to lock in the symptoms, and it can move somebody toward more chronic illness. Along with the symptoms of re-experiencing and avoidance, of course, are excess arousal, irritability, lack of sleep, poor concentration, increased startle, a kind of negative emotions, continued feeling of unreality, and distress. And with acute stress disorder,
Sorry to interrupt, just to let you know you have 5 minutes.
Sorry, with acute stress I'm sorry, I can't hear you.
You have 5 minutes.
Okay, I'm not going to fully get through this. So this is 5 minutes for the whole hour? Or I have 5 minutes to continue. I'll
5
continue
minutes until Q&A, roughly.
Okay, just stop me when I'm done. I'll get as far as I can.
Okay.
And acute stress disorder was introduced partly to predict subsequent PTSD, but longitudinal studies indicate that acute stress disorder isn't an accurate predictor for PTSD development in any particular individual. And so I'm going to move through some of these slides a little more quickly because I want to make sure I cover a few things in the 5 minutes. An important thing to be aware of is observable factors that should precipitate early referral for mental health evaluation and assessment. And of course, this would be significant sleep problems or sleep change, or excess alcohol use, or maybe drug use. These would signal a possible or likely conditions such as acute stress or early PTSD, which excess alcohol use is often used to dampen these distressing intrusive symptoms. One should be aware, and this is extremely important, of concussive injury, mild traumatic brain injury, which even with less than a minute loss of consciousness, what we've learned through the most recent wars is that this can disrupt the brain and hamper its ability to recover from emotional traumatic stress injuries. And awareness of this would help one think of, if possible, a little more downtime to help the brain recover from the traumatic brain injury, as well as from any PTSD-like symptoms. Of course, if hopelessness or suicide thoughts are expressed, the person should be referred for treatment. And combat wounds, if somebody has combat wounds and excess pain, that is also a signal that PTSD may be additionally present. And so there's really not a linear relationship between getting acute stress and getting PTSD. I wanted to show you this graph. The bottom line here on this graph is that most people don't get PTSD. Most people manage to recover, to stay resilient. However, there is a group that has high symptoms right at the time of the war, but who can recover over time. But additionally, and I think this probably has to do with the other factors such as wear and tear, internal conflict or moral injury and loss, there is also a group that does worsen over time, over long-term follow-up. And there's another 10-year follow-up by the group in the Netherlands that more or less shows similar findings as this British study. And so lastly, for the few minutes I have, for any allied medical personnel, while PTSD is the most common outcome of combat stress injury, there are other things that absolutely need to be considered and ruled out. And these are listed here. And particularly notable, and I want to talk about, is the bipolar disorder or mood cycling, which actually is more common or frequent after military deployments. It's only caught by careful questioning. Usually I've had the good opportunity to interview people using full, what are called SCID book diagnostic criteria. And whereas the general population has this disorder at the range of around, say, 2%, around more 5 to 6% of people coming back from the war zone mood cycle. And it's important to diagnose it, catch it early, because it's very disruptive. But if caught early, it responds very nicely to medication, particularly Depakote. Most of these families, men, women who may develop this, do not have family histories. It's somehow the stress of the war sets off something which they're prone to, probably genetically, and for them individually, and they begin this mood cycling. So if you catch it early, then it saves them years of disruption and pain. And I'll stop here.
Thank you, Dr. Baker. Thanks a lot. This was fantastic. It's time. We have 10 minutes for questions, comments, ideas, thoughts. Most importantly, at least for me, how would you implement the information that you just received in your daily practice? Because that's what counts the most. Please, questions, comments. There should be an opportunity to ask questions through chat.
Can you see the questions section in the control panel? That should be where the messages are arriving.
Yeah, I see the questions section, but I don't see any questions.
I think there should be some messages.
Could you read them if you see them? Because I just don't see the. Oh, okay, I see the chat. Oh, no, these are not the questions. Olivia, do you see any questions? Because I don't.
Yes, someone has said, what would happen if the patient doesn't like the treatment just because they're getting used to the physical symptoms and feel comfortable? What should we tell them? Thank you.
Can you repeat that question?
What would happen if the patient doesn't like the treatment because they're getting used to the physical symptoms and feel comfortable? What should this person tell them?
I'm not sure. I've met a patient who feels comfortable with intrusive imagery, frankly. If it's true intrusive imagery, which is the replay of this really emotionally distressful event, and one of my colleagues, Rachel Yehuda, described this as an emotional seizure. It comes on the person suddenly out of the blue. It's not like the person calls up a memory. It's not a rumination. It's not like what people do who are depressed, who kind of think on negative thoughts. It comes out of the blue and is a replay of the exact experience, and it comes with all of the negative emotional affect that the person experienced at the time. And I have yet to meet a patient who it tolerates that experience. Now, they may not want medicine, but they may be very happy to try verbal treatments. And the other thing I should point out is there's a tendency often in PTSD to avoid. and it's sometimes hard to draw patients into treatments, verbal treatments, because they're fearful it'll call up these terrible memories, even though they are in fact there. And the person who's experiencing these is usually not sleeping. They're sleeping very few hours per night if they're waking up in the middle of the night. They're feeling distressed and irritable in the day. They're often isolating by themselves. They're very grumpy with their family members, and usually, you know, they don't get used to these. And so some kind of treatment is beneficial.
Doreen, there is a question. I'm reading as it is written. What level of recovery have you noted in your practice involving combatants fresh out of battle?
What kind of recovery do I notice in my practice? And I didn't hear the last part of this.
In combat veterans fresh out of the battle, fresh out of combat.
Well, I don't fully, so I showed those graphics, and in the slide deck that I sent, there's another graphic. What I'd like to do is send you a slide deck which includes both of the graphics. Again, some people never get symptoms. Most people don't. 85 to 90% don't get symptoms. But among those people who get symptoms, there's a group who does recover somewhat, but usually not fully to baseline. And then there's a group that gets worse over time. And these nice longitudinal studies, which were able to track people before and throughout this time frame, they track people over 10 years and 14 years respectively.
The next question is, what is the difference between trauma and phobia?
Phobia is usually very specific to a single, you know, observable thing. Like you can be, you have phobia of heights, which you can't do. You can have phobia of spiders, and it's phobia usually is more starts earlier, isn't typically related to a trauma-like event. It might be related to an event in a child, for example, a child who's bitten by a dog. But it's a trauma event is very much broader and encompasses typically much more of somebody's life and existence. A phobia is much more kind of contained and much less disruptive overall, typically.
Thank you. What is the role of benzodiazepines in treatment of PTSD, considering the addictive nature of the benzodiazepines?
Well, I would say that I try very hard to avoid them and not use them in treatment of my patients. Exactly that they're addictive and they're not curative. So I tend to use, they don't treat, you know, they may treat the anxiety very temporarily, but you then can't discontinue them. And they're not helpful over time, and they don't broadly help the symptoms. We now, I mean, it's a whole additional lecture to go into some of the medicine treatments, but the two most common treatments that are used for chronic PTSD, or even would be the serotonin reuptake inhibitors, or things like treat the serotonin system. It doesn't work for all the symptoms, but it particularly is helpful for somewhat decreasing the symptoms and particularly the irritability. And so it allows the veteran to live around other people more easily. And in particular, the most helpful drug is actually prazosin, which at the proper dose can knock out those nightmares and allow the person to get some sleep.
Wonderful. Here is the question. You said there are questions to ask to rule out bipolar disorder. What are some of the questions should you ask?
Okay, so here's how I go about asking about this when I do, and it's an important question as part of the first diagnostic interview. I ask the veteran typically, have you gone 2 or 3 nights without sleeping and still have plenty of energy? And many veterans will say yes, and I always ask the question twice, because many of the veterans mishear you. They only hear the part of the question that says, have you gone 2 to 3 nights without sleeping? And so I repeat it, and I say, and you still have plenty of energy. And then most of them will say, well, no. But a few of them will say, yeah. And then you start going very strictly down the DSM-5 list for bipolar disorder. Well, did your family notice anything different about you? And did they notice anything different about the way you were talking? And oh yeah, they noticed I was talking a lot more and a little faster. And is there anything else that was different about that time? And the most common phrase that comes from the male veterans is, my wife holds the checkbook. And it's because during these episodes, they've gone out and bought 3 cars in a 2 or 3 week span of time. It's not this very high level manic-like behavior of which that you see in some of the family members of people who have bipolar order. It's a more bipolar 2, but it's very disruptive. And if you can identify it, it often co-occurs with PTSD, but if you can control those mood cycling symptoms, the other things stay in control. And for the younger veterans, often they don't want to hear you the first time when you tell them, you're mood cycling. And you should take this medicine. But I've actually had some of these veterans who we describe to them what they have, who a year or so later have come back into the ER when they had another episode and said, I was told I have this, and they came back and started taking the medicine.
Thank you. Let's do one more question, and I just want to assure the participants that all the questions that we do not have time to go into will be sent to Dr. Baker in writing via email, and you will get the response. Here is the question. One of the common comorbidities is alcohol and drug use disorders. What is the best approach, especially when the alcohol is used to self-medicate?
Well, that's a big question. That's a whole lecture. And
right.
So I would just say simply, it depends on the propensity of the veteran to be dependent and to be able to stop the alcohol use. The first step is to explain if it's being used to treat the intrusive symptoms, really just to explain that to the veteran, and then to substitute for the alcohol some appropriate medicine, like a serotonin reuptake inhibitor, and begin to engage the veteran in good treatment. So I've had many veterans are in that category, but I've had other veterans who are just very prone to alcohol dependence, and then that's really a lecture that would fall in Dr. Kuznok, your area, and
we're planning this. Yes, we are planning this. Okay, our time is over. I just want to, again, thank you, Darlene. This was fantastic. And I want to thank all of the participants, regardless where you're from. I know some of you are in Ukraine. Many others are in other parts of the world. It is really, really great to have you as participants. Your questions, Olivia, do you mind emailing me, making just one email with all of the questions that we did not have time to answer? So we will be able to answer the participants in writing.
Absolutely. Yeah.
Excellent. Thank you so much. And we will see all of you and probably even more people at the next webinar.
Okay, bye.
Thanks a lot. Olivia, thank you for your help. All of the participants, take good care of yourself and each other. Stay healthy, stay active, and let's help brave people of Ukraine. Thank you.